because at this stage, you are going to see the bone loss, the soft tissue instability. You need to see the collateral ligament status. You need to adjust your joint level. And here you have to have something in the mind. Now, what I'm going to use, how I'm going to do. So you may have a situation where there is a good, normal looking, pristine looking bone after removal of the implant. Or you may end up having a major bone loss, like an ice cream cone in the tibia and femur. So this is the time where you are going to look and assess what is going to happen next. So 3-step technique suggested by Kelly Wins. We always re-establish the tibial platform, then stabilize the knee in flexion, and then the stabilize the knee in extension. These are the principles on which we should work. So we do a minimum base level tibial cut, create a flat platform, assess the bone defect. Now, what bone defect we need to cover with, like a bone grafting, wedges, blocks, augment, sleeve, is going to be covered in the next stop. But we do not try to eliminate the good bone just to make a level. So do not go to the red line. Just go to the minimum bone cut and you cut the defect. Rest of the things we have to manage. Don't go and cut the normal bone. Assess at this level. Always in the revision case, we need to use the stem and we need to do the reamer. As I said, the different type of bone defects will be covered by the next speaker. But here is the level where we assess the bone defect after the minimum tibial cut. Here, we may need augment. So the PCK system has got excellent augment. And what is that? It is stackable, innovative. It reduces in size. You can add one on other. It can just replace the significant bone loss. And the problem of jutting out of the augment, which was there or which is there still in number of other systems, is not there in that. So you have a good PCK augment which is stackable and gradually reduced in size. This is an advantage of the PCK system. As I said, almost every cases in revision, we use the rod. So this system has got excellent options available for the rod. You have a short, fully cemented rods. You have long, uncemented rods. Both of them have their own indications. So when to use what, I don't go into the details, but we have options available for both. But if you are using a long rod, make sure that you do the metaphyseal cementing because these are uncemented rods. And the rod needs to be parallel to the long axis of the tibia. And for that, in this jig, we have excellent intramedullary cutting jig along with the augment cutting slots. So there is a facility available in the jig where you can do and use the augments with the same jig. This is very important. And as I said, these next generation rods in this PCK system are excellent. Cemented are COCR, uncemented titanium, large diameter option from 17 to 18, and a good length option from 30 to 250. Make sure you have a huge number. And the slotted stem to prevent the diaphyseal stress and the pain in the lower tibia. So it's quite innovative in the length, diameter, and other options we have in the rods. Most important thing is offset. So this rod system also gives you an offset because it improves your component alignment, and the overhang can be prevented by using the offset stem, and the load can be properly transferred if you need to use that. So the rod system of PCK, we have all the options available to use in this. Metaphyseal sleeve or a cone is going to be covered by the next speaker in the bone defect. But we know that sleeve is a part of implant, gives excellent stability, but there is a huge problem of a size in the Indian bones. We have to be careful. Cone, of course, is not the part of the implant, is a natural feeler because of the low modulus of elasticity. It has got good osteogenesis property because of high volumetric porosity and bactericidal. So both of them have its own role, where to use sleeve and what to use a cone, which the next speaker is going to cover. But of course, if the problem of size is in the sleeve, problem of cost is there with the cone. Now, you have just done the tibial platform and try to sort out the defect, use the rod, offset, long, short, you made your tibia. Now, you stabilize the knee in flexion. So do not fit the corresponding femur to existing bone. You can see this femur bone here. Don't take up the implant trial and put it to this. This is not your actual femur you are going to replace. This is the leftover bone. Do not fix the trial implant to this bone. You may get a size C, but you may require size E. So do not fix the trial into this bone which you see there. Therefore, I told you that always check the femur implant which you have removed. If required, try to see the contralateral X-ray and make sure what is your expectation. The most important thing is AP location and sizing of the femoral component, right? And it is very important because we know that to adjust the flexion, and what is the problem? The most crucial thing is the femoral component positioning and the concept of the index hole, where you are going to do the hole, the femur hole. You have to be very careful about that. Try to do little posterior, because ultimately you would like to bring your femur component down. By bringing it down, you will reduce your flexion gap, which is a major problem. And at this time, this place, we have two things to see. If you bring it down, you will reduce your flexion gap. If you bring it up, you will try to adjust your joint line. So both these things will be done, whether you want to bring it out and distal or you want to bring it down. If you want to bring it down, you really need to do the flexion gap need to reduce, because it is usually more. So there are various ways. Upsize the femur. By doing that, you will be able to correct about 6 mm, the gap. Then posteriorize the femur. You do the index a little down, bring it down, another 2 mm. You use the posterior offset stem. By that, again, you will be able to bring down another 2 mm. So up to 12 mm of gap mismatch, you will be able to do and just reduce your flexion gap by bringing the femur down by the various ways, or you increase your extension gap. That is another way of doing so, but there is a limitation to that. You can't keep on cutting the distal femur more and more. So this is the case where we have done the posterior offset stem and try to bring the femur down to reduce the flexion gap. This is what we need to do. Now, posterolateral augment will give you an external rotation or use epicondylar axis. So this is where you try to stabilize the femur in flexion, try to reduce the flexion gap, make sure it is externally rotated, and if required to match the joint line, try to bring it out, so that you might have to use the distal augments. So the options, again, like the bone defect at this stage, augment, sleeve, short cemented rod, or large canal filling rods, whatever you want to use, you have that option available in the PCK system along with the offset rod also. So these are the things which we need to do. Now, after that, you need to stabilize the knee in extension now. Now, what is the problem? If it's hyperextension, you need to bring distal augments and try to bring your femur out so that the extension gap is reduced. Sometimes if there's an FFD, you might have to carefully resect, not too much, the major joint line or do the soft tissue release. So after tibial platform, after stabilizing the knee in flexion and then the stabilized knee in the extension, you are there where you can select. The system PCK has all the options available. For femur also, we have reversible distal augments, the posterior augments, the uncemented short rods, the offset rods for the femur are also there. And here we have to decide the constraint after this. So do you, according to the soft tissue balancing, the load transfer and implant stability, you will decide what type of constraint you want. It is not necessary that all the time you do revision, you have to use a constraint joint. No, that's not the case. All the time you have to use a hinge joint. That's not the case. If there is a gap which is more than 12 to 14 mm mismatch between flexion and extension gap, then you need a constraint. As I said, up to 12 mm of flexion gap, we can manage just by changing the femur, using the offset and other things. So CR, Dr. Ashok Rajgopal's few cases I've seen where in the revision scenario, he has used a CR knee. Most of the time, we can use a PS or a PCK or a hinge. If a huge gap mismatch, more than 14, 16, 20 mm, then probably you might have to go for a hinge. So either a CR, a PS, or CCK, or RC, or RHK. Like this is a choice of constraint where we only did a PS by revising the uni, no rods, no augments, we could manage to do. So it's not necessary that all the time you have to go for an implant where you need to use a constraint. A second case, second stage of revision, we have not used constraint. We have used the PS knee with rods on both sides, good balancing. So this is what we can achieve. This is a third case. The X-ray doesn't look too bad, but the bone quality was very poor, periprosthetic fracture, nothing much to do the control, and we had to use something like this after this. Whether you need a tumor prosthesis or a constrained hinge type of or a PCK type, you have to decide at this stage. But you need to have a good planning and keep everything ready and available. The other important system benefit with the PCK is a constrained liner. So this pin, which you can see here, is fully threaded into tibial base plate, right? Other system has got a rod or a pin, but it doesn't fix with the tibial base plate. By doing this, it reduces the 19% of the stresses in the lower thickness liner, especially when the liner option is thin, right? This securing the pin with the tibial base plate gives you an additional stability and reduces the stress, which is another important design feature of the PCK system, and 11 to 31 mm options. So it's a huge range of the liner thickness options you have available with this. Another important PCK, it is progressive constrained femoral box. So the current tibiofemoral constraint systems, they provide a constant level of constraint throughout the range of motion. Extension to flexion, the constraint level remains the same in the current available constraint systems, whichever company you take. So Freedom PCK provides a varying constraint profile from high constraint to less constraint as you flex. In the extension, it is very well constrained. As you flex it, the constraint reduces. That puts less strain and gives you some additional range of movement. This is done by the special design of the box. Like it has got this trapezoidal shaped femoral box where the narrow end is anterior. And by doing this, what you get is that in extension, there is more constraint between the tibial post and femoral box. And there is no varus valgus or the internal external rotation possible, but at the joint goes into the deeper flexion, the clearance between the tibial post and the femoral box increases. This allows you in both varus valgus tilt and some rotational movements possible with less strain. You do a lot of good job. I was asking to Dr. Bansal about his, and he said that in hemophilia cases, they delay the mobilization by 1 week. So here, post-op rehabilitation in a revision scenario is also important depending on what type of bone defect, what type of implants you have used, what constraint you have used, what was the balance. Depending on that, you delay your weight bearing. DVT prophylaxis and already a talk by Sujoy on osteoporosis treatment is very important. Please do not forget this. Now, see, this is the case where the patient had a painful knee. The cause was some tumor in the fibular head, right? And we had to do this type of implant revision. Another case, aseptic loosening of old IB2 type of thing, a sleeve and rod with a constrained implant. You can see the defect, and this type of implant was used in this case. This is another PCK system, bilateral infected case. The second stage, we use the rods and the PCK. There was no need for any offset rod, but we have an option of long rods available with PCK constraint in this type of bilateral infected TKR. So anytime, as I said, depending on the situation and the principles which I told you, we have to decide and select what type of implant you would need. You would need PS or a PCK or a hinge, short rod, long rods, defect management, and constrained liners or not. So it all depends on the things which you do and decide. It's another case where you can obviously see the collateral ligament is gone, and probably you need something like a hinge in this because that's the only option available for this type of problems. So what I would like to conclude is that you really need to do a good planning, adherence to the principles to overcome the daunting challenge of revision knee arthroplasty. Try to follow the principles, try to base the tibial base platform first, and try to stabilize the knee in flexion and then stabilize the knee in extension. Wherever you want to use the material for the bone defect, you do that and try to reduce your flexion gap. Use the rods, either a short cemented or a long rods. Do the cementing in the metaphyseal part only if you are using the long rods. The PCK system is very versatile because you have option of everything available. You have augments available, offset rods available, constraint system available, constraint liner available, normal PS available, PS with rods available. So that's the beauty of the system with the PCK. Thank you for patience hearing, and thanks. Thank you.
Thank you, Dr. Deepak Dave. These are excellent presentations. Thanks a lot. Next presenter, I'm inviting Dr. Subhash Jahangir. He'll be speaking on the principles of revisions knees. Sir, what is the protocol between two stages, stage 1 and stage 2? Difference. How do you decide your patient is fit for the stage 2 surgeries? Yeah, sir, your principle.
But the most important point is the markers, the blood markers, and your ESR, CRP. If required, we need to aspirate at that stage, but make sure that your CRP, ESR, and CBC levels are normal, and the second aspiration is also negative. That is what is important. I'm sure the next speaker is going to cover, but most important point for all of us is to know the organisms. That is the key factor, because unless you know that, you will not be able to get a proper antibiotic regime. But 3 weeks IV, minimum 3 to 4 weeks oral, gap of about 2 months, and make sure the markers are normal with second aspiration negative.
Thank you, sir. Thank you. Yes, Subhash.
Thanks, Beryl. Thanks, Dr. Dave. You have made the platform very easy for all of us. Ideally, each principle of revision needs separate talk. It's that vast a topic. But again, there will be a lot of repetitions because of the topic as such, and the requires a lot of hammering to know what you need to do during the revisions. The most important principle is, again, as said by Dr. Dave also, that identify the cause of failure. If you are not able to identify the cause of failure, you will fail again. So if you don't know the reason why it has failed in the first go, you're going to fail again. So this patient has a quadriceps mechanism slipping on the lateral side, and the moment she extends the knee passively, the knee is absolutely fine. She's able to walk without any problem. The only problem is getting her from sitting position. She doesn't want a revision because she is happy like that. But she has come to you, so you need to know the reason why this is failing. You need to have all kind of scans and physical examination, even require an MRI, special MRI and CT scan, and aspiration if you have any doubt of infection. And if you know the major causes of revisions are the aseptic loosening, instability, fractures, wear, and there are a lot of types of revision, right from the total revision to only half, only poly change, only patellar replacement. They've all been considered as a revision in the literature because any reoperation is taken in the registry data as a revision. Now, if we see radiolucencies in the post-op X-rays, the usual site is the medial tibial condyle. That's why you should not lever the tibia with an osteotome, otherwise it will break from that area. On the femoral component, usually the loosening is on the posterior side. You will rarely see an anterior cortex damaged by the old implant, and usually we try to recreate the rotation by the anterior cortex and the transepicornal axis. Shift of the implant, subsidence, or breakage in the cement are the obvious indication that this implant is loose. If you have any doubt, do sequential X-rays, arthrography, bone scan, or the CT scan. Tibial component is more commonly having a loosening than the femoral component. That is why in the long term, the challenge of mechanical alignment is that we don't want to put the tibia into varus, too much of varus or valgus, because that's going to cause the loosening much more quickly. If they're less than 2 mm and non-progressive, these are fine. If they're progressive, aggressive, or with symptoms, that means there's something wrong. You need to get either a CT scan or MRI to find out. Usual causes for aseptic loosening is somewhere wrong in the overall malalignment or the laxity or patient with high demands or polywear or constraint of the implant is too much, and that is causing an impact on the bone cement interface. Polywear, we have seen that can lead to the loosening as well. Malrotation of the component. We very commonly see that the femoral component has been malrotated, and that can lead to the early loosening. And even the tibial component. I came across this case where the tibial component was in excessive external rotation. And after 6-7 years, patients started having the instability problem, and that led to the excessive wear. Instability, you have kept the flexion gap too large. So the tibia is subluxating posteriorly. The patient is having instability while getting up from sitting position, and you can see the under anesthesia, the tibia is knee actually dislocating posteriorly. So you need to do a revision for such cases. Frank dislocation because of the ligamental imbalance, malalignment, or rupture of the ligament can also require a revision. Infection will be dealt separately in a different topic. Periprosthetic fracture, which can happen during the impaction of your component in an osteoporotic bone, or later on because the fall or injury require a revision. Extensor mechanism problem, as we saw in the first video, as the patient is having subluxation of the extensor mechanism, requires a revision. If there's a lag, flexion contracture, patellar tracking, and we commonly see in the clunk, if the patella, or if the femoral component is not patella friendly, as you can see in this patient, there's a lot of synovial hypertrophic nodule at the proximal pole of the patella, and patient was having the clunk syndrome, and we need to remove this socket. But I have seen that these patients, they again develop the synovial nodule, a lot of them, because the femoral component is same. We are not revising the total knee. We are just removing the synovial nodule. We have done that arthroscopically as well, but they all come back. Almost 50% they come back, and 50% may be going somewhere else. So I presume that this synovial hypertrophy will keep on coming because the irritation factor is not going. So you need to do a proper planning. What is the type and size of the previous implant if you're doing a partial revision? What approach to be used to have good exposure? How we are going to remove the implants? What is the polymorph count? So when we open the knee, even if it is an aseptic loosening, we are not suspecting infection. We take the fluid, send it for the immediate frozen to know what is the polymorph per high power field. If they're less than 10, you're sure it's not infection. If it is 10 to 15, I would keep an antibiotic cement. As usual, we use an antibiotic cement for the revisions. And if it's more than 15 or 20, we obviously take the patient for a 2-stage surgery. Nowadays, the dire procedure, we are doing more and more. And sometimes we go ahead and do a thorough debridement and take multiple samples and go ahead with the 6 weeks post-op antibiotic as well. So I've done till now 3 such revisions, single-stage revisions. And so far, fingers crossed. Implant inventory, as discussed, you need to have know the canal size. So if you're looking at a very small canal, you need to have the smaller size stems as well, sleeves and cones. So you need to sometimes have a mix and match because not every company is having all the things. Special instruments to remove and light day for yourself. Don't keep your day too busy on that day because you may have to go from plan A to plan B to plan C depending on the surgery, and then under the stress of a lot of things doing on the same day, you may tend to make mistakes. So if we talk about some general principles, the joint line should be reconstructed. Bone defects should be managed properly. Knee should be stable when you end your surgery with a good soft tissue balancing. And if they're inadequate, you go from the least constraint to the higher constraint. The limb alignment should be ensured. We use the IM rods in the revision surgery. Solid stems, whether you want cemented, uncemented, personal choice and depending on the bone quality. Rigid fixation to improve the survival. Patellofemoral mechanics are mostly ignored. They need to be taken care of even in revisions. Gaps should be managed by the augments, and any scar tissue synovium we remove so that the patient get a good flexion or good range. So good exposure desired. Whatever approach you want to use, you may have to use a parapatellar, the cordyceps snip. I have not done the VY-plasty. I will resort to the tibial typical osteotomy rather than going for an VY-plasty. Now, component removal is the first thing to be done, and femoral component is removed first so that you have a good area to move and work on the tibia. Osteotomes should be used between the implant and the cement interface rather than between the cement and the bone interface. Osteotomes, saw, giggly saw, you need to use between that surface so that you don't damage the bone, because if you use it between the cement and the bone is weaker than the cement and your instrument is going to drift towards the bone and can damage the bone. Patella component, if it is well fitted, no wear, I will try to keep it the same because all patellas are spherical patellas. You need not to change depending on a component. If you are changing the main component company, you need not to change the patella. If required, if they are damaged like this, you definitely need to remove them because they're going to wear further. Now, how to remove the femoral component? So as we discussed, you need to either use a fine saw blade, either a reciprocating saw or an oscillating saw. These fine, small saw you must be having in your OR. You work between the cement and the implant interface. Be gentle, no need to be in a hurry because the moment you slip, you will damage the bone because the bone is soft. Bone is the weakest link here. And if you slip, it will be damaging the bone, and you need to preserve the bone so that you can have the good outcome and the least constrained implant for your patient. You can also work with the osteotomes, work around the curve of the implant, anterior flange, anterior chamfer, distal cut, and we also the special osteotomes to work on the posterior part of the implant as well. So move between the all around the area. If there are pegs, you can't go beyond the pegs. If there is a box, you can't go beyond the box. So you can reach up to the box. You can clear everything. You can also use the giggly saw if you want to. So all these things have been used in different types of patients depending on the requirement. Giggly saw gives a complete clearance from the anterior side and up to the anterior chamfer. And then you can use the special instruments to pull the femur out. Even if there's a box, only the box is now cemented. And that much bone we are anyway going to remove because we're going to put the stem inside. So then you can pull from with the special instrument, and you can see there's hardly any bone damage when you remove the component from the femur. Same way on the tibial side, use the saw blade between the component and the cement. There's a keel in between, so you can't go beyond that. There are special osteotomes like a C. So we have those in our OR and we can work on the back side as well. But most of the time, the half of the tibia is already loose. The other half is not that loose. If you can work on that side, then you can use our osteotomes to either bad osteotome or you can, we also have the foot punch. So that will lift the tibia up. And once you lift the tibia up, you can easily take it out and without any damage to the native bone. The cement is intact there. And then it's very easy to remove the whole cement from there. Now the 3-step technique. First, you make the tibia platform, then balance the knee in flexion, and then in the extension. So first you prepare the tibia, cut as minimum as possible because you need to reconstruct. And sometimes you don't even cut because you know there's too much of defect. And the more you go, you see the femur and tibia both are conical. The more bone you cut, the more smaller process you're going to use and bigger the gap. So we try to retain as much as possible. And if required, use a cone or sleeve to lift the whole platform up. So every system has reamers. You go step by step. And on the last reamer, you will put an attachment to know how much you're going to cut or whether you have to cut or not. So on the same reamer, you will be attaching the cutting guide, and on the same guide, you can see whether you need an augment on the tibial platform or not. Same way, the rotation of the femur. So as I told you, the anterior femur cortex is usually intact. It's not damaged. That is your rotation if the primary implant was also in the proper rotation. If not, then you can use a transepicondyle axis to manage the rotation. And then you see how much is the gap on the posterior condyle. That much augment you need to put, and then you know that this is the ideal size. You have to see what size of the component has been put in, suppose size C or D, try to match the same or maybe size lower than that, if that was an ideal size for that particular patient. If required, you need to move the femoral component anterior, posterior, medial, lateral. So you need to use the offset stems in those cases. So same way we use on the femoral side, we go step by step, use different size reamers to reach, and then if required, you just make it flush to your desired level. After putting the femur on the femoral component, the tibial component, then you extend the knee. If your knee, you're able to distract, that means there is some extension spacer you need. So you need to use the augments on the distal femur, and then you achieve a good stable implant. As you can see here, you need an augment on the distal femur so that your extension space matches with the flexion space. Joint line, there are a lot of calculations you can do, but as a benchmark, good guidelines, 1 finger breadth below the lower pole of patella or 1 finger breadth above the head of the fibula. So that's what Dr. Dave described what you need to do. You can move the femoral component up and down. You bring it down, you reduce your flexion gap, you bring it up, you increase your flexion gap like that. You can mix and match whatever is required in that particular case. Bone defect is the next talk. You can use this cone to build up the bone and cone along with the augments to match your extension gap. Hinge, if the collaterals are absolutely not working, then you need to use the hinge. As you can see in this video, even despite using the trial components with the LCG type of prosthesis, the medial opening is there, and this will fail from day one. So you need to use a hinge in such cases. The jump height is 40 millimeter in one of the companies. Different companies have different jump heights. So few examples. There's the same patient which we saw the video how to remove the components, and then we prepared everything and did a LCCK type of implant. And you see the tibial stem is an offset stem because that's important. You need to cover the base, and then accordingly where the canal is going, you need to use an offset stem. On the patient, the femoral component is sunk in on the left side. Use an allograft to build up the area and used only the femoral component revision. Very old component, lot of metallosis, hyperextension. The poly was completely worn out. Metal was hitting the metal. So removed everything. On the tibial side, use the allograft to fill the defect. On the femoral side, use the allograft to build up the femur. When there's a complete damage to the distal femur, and that's why I say that whenever you're using a constrained prosthesis, use a stem on both the sides. Otherwise, this fracture has happened only because the stem was not used on the femoral side. Otherwise, probably this patient would have lived a normal life with this kind of prosthesis. So the femur was completely loose. It came in the hand. And you need to resort to, and you need to revise the tibia as well, because this tibia is not compatible with the rotating hinge type of prosthesis. So use these kind of extraction instruments where the stem is there. You can remove this completely without damaging any bone. So use the LPS system of the J&J. So results of revisions are not as good as primary. We all know that. And in a different series, the good to excellent results are only 46-74%. Extensive mechanism complications and deep infection are the two major risk factors with such surgeries. One word of caution that before jumping for revision, look for other cause of limb pain. Don't miss the hip arthritis, significant deformity of the foot and ankle, and assess the patient's personality as well. So identify the cause of failure. Ask for the old records, plan properly, follow the principles, rule out infection, be wise, don't just repeat, revise. Thank you.
Thank you, Dr. Subhash, for excellent work. Next speaker, Dr. Jagdish will be speaking on management of bone loss in revision knee replacement. Subhash, can you ask me a question?
Yeah, sure.
How do you decide? What is your criteria to decide go for the stage 1 or stage 2?
So if if you are able to identify the organism, you are lucky.
No,
First
most of
thing.
the times not.
Most times you are not, because patient already on a lot of antibiotics. Then I go for the blood parameters, the ESR and CRP. If they are not very high, if the CRP is not more than 20, ESR is not more than 50, I'm okay to go to the single stage. And patient's immunity level. If the patient is not immunocompromised significantly, I will probably look for a single stage revision nowadays. Fungal infection is a big no for single stage.
Do you feel that if there is any local sinus or something, wound is there, do you feel that that is your decision?
Contraindication.
Contraindication. Exactly. I'm doing a lot of single stage, but anything wound outside the knee skin, that is will not go for the two stage.
So if just time permits, I just share a 2-minute story. So I had a patient who had an angioplasty, and after the angioplasty, he started having significant pain in the knee joint. No relation at all. We kept on finding the reason, couldn't find out. We got MRI, nothing came out. After 3 months of follow-up, despite giving a lot of analgesics, all other chondroitin sulfate, other, because PTCA was there, so nobody was trying to jump in and do anything. Another MRI showed a lot of punched out lesions in the femoral bone. So we thought it's significant damage to the bone. Reason, don't know. Parameters, normal. ESR, CRP, blood parameters, everything normal, counts normal. We offered him surgery. We went in, did. The moment I cut the box for the PS knee, there was a pus pocket on the backside. So you already committed everything, taken all the cuts, and the dire reason at that time just came in the market. So we went in and we thought, okay, let's do a thorough debridement. We did the wash, complete wash with betadine peroxide, 6-liter wash, changed all the drapes, and went ahead with an primary knee and kept him on antibiotic for 6 weeks. That patient did well. That boosts your confidence to do a single stage.
Yeah, we are doing I'm doing a lot of single stage. Only issue is the wound. If there is a wound, go for the two stage. Thank you very much.
These are absolute contraindications. A draining wound is big no.
Yeah.
Good afternoon, everybody. Thanks to the Merrill team for giving me this opportunity. I'm going to talk on management of bone loss in revision. So mainly the bone loss is due to the consequence of the previous surgery. Yeah, sorry for the delay. So the challenge, previous speakers have spoken everything about how the principles and how to manage the revision cases and all. The challenges what we face is fixation issues and ligament instability and bone loss. I'm going to talk on bone loss. So for any surgery, either primary or revision, you should do a good preoperative planning. A small quotation by Abraham Lincoln that if I had 6 hours to chop down a tree, I would spend the first 5 hours to sharpening the axe. The same applies in surgery also. You spend more time in preoperative planning rather than spending time in war. before going to the surgery, so especially whenever you are doing a revision in a remote place, like in a small town or thing, keep everything available, like implants, stems, wedges, augments, screws, cones, sleeves, even bone graft, either allograft, autograft, and hinged knee. This is a very important. Suppose if you find a ligament instability on table, you need a hinge. So radiological evaluation bone loss, the plain X-rays will give you the some extent of the bone loss only. That CT will give the more informative in analyzing the bone loss. Better to take an CT. It's a widely used classification. This helps in the management also, like Anderson Orthopedic Research Institute, AORI. These got the 3 types, type 1 and type 2A, 2B, 2-3. So type 1 is an intact metaphyseal and cancellous bone at original joint line. If it is less, means most of the times it's a minimal bone loss only, less than 5 mm. This can be managed with cement with screws or intramedullary stems, either cemented or uncemented, as upon your choice and bone quality. The intramedullary stems offload implant host bone interface. So I'll show you some of the cases how I managed the type 1 and type 2 and type 3. What you are seeing in the slide, that preoperative X-ray, it's aseptic loosening. It's not X-ray is not giving much bone loss and all. So small when you remove that implants, you will see the original bone loss. See, removing the implants also very important. While taking, minimize the bone loss in femur and tibia. This has been managed with primary components like tibia and femur, and managed with the intramedullary stems. So you can see the 8 years post-op X-ray. It looks still it's good. So doing good. The main principles earlier speakers has told that in revision you have to maintain the joint line, posterior condylar offset, and posterior slope of the tibia. For all these, you need a stable fixation, stable basement to fix the components. One more example, type 1. See, that's straightforward, but the only thing is here the loss of the femoral condyle, because if you go as the bone is present, you are going to elevate the joint line. Here, you to maintain the joint line, you have to distalize the femoral component. Here, what I managed is I put some bone graft with the screws and all, distalize the femoral component to maintain the original joint line. These are the intraoperative. You can see the lateral view of the intraoperative photo. It's been filled with the cement, that bone and screw. That intramedullary stem that gives to the axial and rotational stability here. So one more case example is type 1. So same like here the bone loss is managed with mercerized bone graft. So you can see the 5 years post-op. In type 2A and 2B managed with actually it's sorry. Type 2A and 2B managed with the screws, cement, even wedges, augments. It's a loss of damage of metaphyseal and cancellous bone. It's one more type 2 example. Already you've seen how to remove. These are the after removal of the components. You can see that femoral component, lot of bone loss at the femoral condyles. Here, because of the financial constraints, I have not used any wedges and all, managed with the screws and cement. See, you can see this pre-op X-ray and post-op X-ray. This is a 9 years follow-up X-ray. Still patient is doing good. Here I have used, because of the bone quality is not good, I used cemented stems with the screws and cement. That joint line is well maintained, and posterior corner offset also well maintained. This literature says that Lockheed or Ritter, they says that in simple type 1, type 2 can be managed with screws, cement with the screws and intramedullary stems. That gives you good results. Modular metal augments, these are used in type 2 also, easy to use, available in different shapes and sizes. You can allow the patient immediate weight bearing. Advantage of this is you can maintain the joint line by distalizing the femoral component, and you can maintain the flexion gap by putting the posterior condylar offset properly, posterior augments femoral component. So one of the case uni has been revised here. Femur side is not much bone loss, managed with primary femoral component. Tibial side is tibial defect as managed with tibial augment. These are the pre-op and post-op X-rays. You can see the patella is tracking very well. In literature, metal augment results, J.V. Patel, they used in one or two cemented revision TKA in type 2 defects, treated with augments and uncemented stems. 7 years follow-up, 92% survival rate at 11 years, 14% non-progressive radiolucent lines, no significant complications. Means you can use the augments. When it comes to the metaphyseal sleeves and porous tantalum cones, metaphyseal sleeves, this gives the fixation as well as the augmentation. The advantage is both when you use metaphyseal sleeves. The cones only, it gives the augmentation. So it can be used in 2B and 3 defects. It's easy to use. It's available in different sizes and shapes. You can allow the patient weight bearing immediately, no resorption. Only the difficulty here, it is when you want to remove, it's very difficult to remove. So one of the case example where used cones. The manganese in literature, manganese RM et al. The 15 revision TKA with a tibial cone in type 2B and 3, 12 cemented stem and 3 uncemented stems, 34 months main follow-up. They say that all demonstrated osteointegration as well as no failure. Same in femoral side also, Harvard has presented that no failures. When managing with type 3 defects, here the loss of the one condyle or two condyles is a huge loss in the metaphyseal region as well as the epiphyseal region bone. See, this already failed revision. So 2-stage procedure has been done. Cement spacer. Here, huge bone loss at the metaphyseal region. You can see the ligaments are intact. Here, used metaphyseal sleeves, both femoral and tibial side. This is a clinical. To know the original bone loss in bone, the femur or tibia. Here I have not prepared with the segmental replacement implants. Once I removed the tibial component, I found that there is no proximal tibia at all. Somehow I managed with cemented metaphyseal sleeve with stem, but it's not good for a long-term results. That you should keep everything ready, then only you should follow that. You should start the surgery. See, this is a pre-op and post-op. You can see that there is no proximal tibia at all. Ranawat presented the 33 revision TKA, 2.3 years main follow-up, 84% complete osteointegration, 16% partial osteointegration and stable, 0% unstable and subsided. Means you can use the metaphyseal sleeves. It gives good results. Segmental replacements are very helpful in the periprosthetic fractures, elderly people. 4E, the type 3, especially femur, we can do the quick 44 revision TK rotating hinge, 4.2 years main follow-up. Means whenever you're using segmental replacement, you should use with the caution, because you will face with lot of extensor mechanism problems. Structural allografts in type 3, you can use especially in tibia in association with extensor mechanism compromise. It's a time consuming, prolonged period of modified weight bearing, sometimes late graft failure or graft resorption. So one of the case examples where I used the bone graft. Backstain that 61 revision TKA with structural allograft used uncemented stems, 5.4 years follow-up, failed due to graft failure, 21%, remain an option in difficult cases. The key thoughts in type 1, type 2A, you can use cement or screws with cement, standard augments for small defects, and type 2B3 metaphyseal sleeves, cones for larger defects. Massive segmental femoral bone loss, use segmental replacements or structural allografts. Massive tibial bone loss, use structural allografts, especially extensor mechanism disruption. Thank you.
Thank you, Dr. Jagdish. It's excellent talk.
Thank you.
And I think I have also very good experience putting only the screws and cement. Because many of the times, if you want to put the wedges, you have to cut the normal bones also. You have to make a space for that.
Yeah.
And then it acts very good.
Yeah.
It does well.
In literature, it is proven. Only thing is in where you are practicing in part of this thing is our packages are very less. Once you start putting arguments, the revenue will.
Because you are working in the India, then you have to keep money is a constraint.
Yeah.
Big constraint is the money. Putting a wedge and putting a screws, there's a lots of difference out there. And it acts very good.
Yeah.
Only screws and cement. Augment the distal femur.
Yes.
It does well.
Yeah.
And you have shown a couple of cases. Good. Thank you.
Thank you.
Next case, Dr. Venugopal. He will be speaking on the two-stage revision.
Good afternoon, everyone. I thank the Merrill Academy for giving me this opportunity to share my experience on two-stage revision TKA. So why two-stage revision? Two-stage reimplantation is considered as a gold standard in the literature. Why means failure rate of a two-stage revision following a failed DARE procedure has been reported as high as 34%. So two-stage reimplantation was first described by Inserson. What are the indications for two-stage? Chronic PJI and infections with highly virulent organism, and mainly in the immunocompromised host. So stage 1, it involves removal of the prosthesis. Removal of well-fixed components carries the risk of destruction of bones and adjacent soft tissues. So all efforts should be made, however, to minimize the bone loss. So radical debridement of bone and posterior soft tissue is most important, as the posterior capsule is one of the major source of reinfection. At least minimum of 3 to 6 tissue samples, including that from the medullary canal, as well as the posterior capsule, has to be sent for tissue culture. And after the stage 1, after removal of the implant and the radical debridement of the soft tissues, antibiotic impregnated cement spacer has to be kept as an intermediate space. So the role of the spacer here is to preserve the joint space and to reduce the soft tissue contracture while delivering high doses of antibiotics. So there are two types of spacers. It can be dynamic or static. So static spacers, they lead to loss of range of motions and quadriceps shortening and wasting, but they are recommended for cases with massive bone loss and lack of functional collateral ligaments, and where there is a secondary need for soft tissue reconstruction. So dynamic spacers, they have the advantage of maintaining range of movement, maintaining quadriceps length and strength, better patient mobility between the stages, and it gives an easier and better exposure for second stage surgery. So antibiotics which are available in the antibiotic impregnated cement are not sufficient because they contain only prophylactic dose of antibiotics. So we have to add more dose of antibiotics into the antibiotic cement. At least it should be up to 20% of the total mass of the spacer. For example, it requires at least 2 to 4 grams of vancomycin per 40 grams bag of cement. So post-op antibiotics, again, as earlier speakers have told, it should be for 4 to 6 weeks. First 2 weeks are IV antibiotics, followed by 4 weeks of oral antibiotics. After completion of antibiotic therapy, there should be a 2-week antibiotic holiday. So, and it should be clinically followed to detect any signs of continued infection. So when to do reimplantation? At present, there is no single current investigation which accurately or reliably determines eradication of infection. As literature advises, or as my previous speakers have told, that they will depend mainly on serum inflammatory markers, ESR and CRP. But the sensitivity as per literature is very less, and the knee aspirates for polymorphonuclear percentage as well as the cell count and culture of the synovial fluid is also have inconsistent sensitivity. Coming to the other thing, they advise in the literature, what advised is frozen section. Many of them are doing frozen section of tissues, but even this also has only 25% of sensitivity, but they have high specificity. So current protocols at present remains inadequate to address the timing of two-stage procedure. So when to do? One should depend on their clinical thing. So when the knee appears to be clinically ready for further surgery, when there is no warmth and the patient is painless and there is range of movement in your dynamic spaces and patient is medically fit, one has to go for the second stage. Typically, it takes between at least 2 to 3 months after your first stage. So second stage, the bony preparation will depend specific to the design of the component which you will be using. And one should see this as another opportunity to perform aggressive debridement to eradicate the infection. So post-operative antibiotics should be continued as long as intraoperative culture reports are available. And if the intraoperative cultures are positive, again, prolonged antibiotic treatment based on the sensitivity should be given. So I'll give one case scenario. It's a 56 male with a primary ONE, patient on hypolipidemic drugs and aspirin. His total protein was 6.7 and creatinine was 1 gram. He underwent primary TKR with the PS. Apparently, he was all right for 2 years with range of movement of 0 to 100 degree. He had a trivial fall at home and developed a swelling. So there was an tribal loosening and there was pus and aspiration. So planned for 2-stage revision. So patient developed acute kidney injury, hypertension and COPD, was treated and planned and treated with implant exit and antibiotic spacer. So dynamic spacer with gentamicin plus vancomycin was kept. Intraop findings were bone loss plus both femur and tibia. Both collateral ligaments were intact. 3 knee aspirations at an interval of 3 weeks were done, which all came negative. Renal parameters were normalized. Total protein count was improved from 6.7 to 7.5 grams. Albumin levels were improved from 3.4 to 4.3. I think this total protein count and improvement of albumin plays a crucial role in control of the infection. And so left revision TKR was done with femur intramedullary stem and distal and posterior augments, tibia with metaphyseal stem with sleeve. So this is a 6 months follow-up X-ray patient. I don't have the clinical pictures to say. So take home message. So staging. One should see the staging as an opportunity for aggressive redebridement and eradication of infection. Spacers, dynamic spacers are better in view of exposure during your second surgery and post-op mobility and timing. One has to depend on multi-factors and is it a gold standard now? But as the latest literature is saying that even after your second 2-stage revision, the failure rate are increasing, it's around 40%. So one has to still think whether it's a gold standard, and still we don't have an answer. Yeah, thank you.
Great. Thank you, Dr. Benugopal. It's an excellent talk. How do you decide your antibiotic regime? Because many of the times you can't find out the bug. Even you aspirate, even you do a lot of things. Even you take the 5 or 6 samples, different part, posterior capsules, anterior capsules, tibia, femur, inner side? No.
Yes, sir. So,
Then how do you decide?
so based on our local area, where we operate in our regional, which organism is more common. Usually in hospital-based acquired infection, we have Staphylococcus, or we compare it with the other infections in our hospital. Based on that only, we go ahead with the common antibiotic regimen. And before going for the second stage, I am looking at the clinical factors of the patient. When he is having painless, there is no local warmth, he is mobilized, he is walking. Based on that only, I am going into the, because as my most of the aspirates will be dry. In intermittent aspiration, or even after your antibiotic spacer, when do you aspirate? Majority of the time, 90% of time, it will be dry aspirates. So you cannot decide on one factor. Thanks. Thank you.
कर लेते sir. कर लेते. There are people will do it. Agenda में रखा है ना करते. So thank you panelists and thank you speakers. We would complete our panel discussion on robotics, which is on the agenda. So may I request Dr. Mohammed Hasil, as he is the master panel, who would moderate the session. We will get Dr. Chandrasekhar on Zoom call. He can connect. I would request all the panelists to please come on the dais. Dr. Neeraj Adkar, Dr. Sanjay Lunde, Dr. Shailendra Patil, Dr. Shekhar Srivastav, and Dr. Sujay Bhattacharya. No more delays.
There are more panelists than the delegates.
Yes.
Last session scenario.
Shall we start? So basically, this panel discussion is to consolidate whatever we have discussed so far in the morning. We have a elaborate discussion on active robotics, the benefits, the risk factors, safety issues. Everything was discussed in detail. And in this discussion, taking into account of every expert panelist personal experiences on this, we need to conclude and we need to make a consensus. And what does the literature say about these things? Of course, we do only have a short-term publications. So to accept any innovation or any technology as the best, or we can go forward with this, we need to find out and we need to emphasize on the unbiased clinical superiority of this technology and its cost effectiveness. So to ascertain these things, we need to look into the economic aspects, how good the technology is getting the alignment right, what's the learning curve, how good is the technology in predicting the implant size accuracy, what's the patient reported outcomes, and the radiographic analysis. So coming to the first part, we have all discussed what's the way we have progressed with this robotic technology from a conventional approach to computer-assisted surgery to the robotic-assisted TK. So my first question is to Neeraj sir. how do you rate your transformation? How do you weigh the benefits out of your transformation into a robotic surgeon?
From conventional, then navigation, I started using navigation in 2007. Brain Lab, Colibri, then Knee3, then some other system, robotic, then over to QVIS. In robotics also, I have seen transformation. So we can add one more heading there from semi-automated to automated. So
The question is
like
again
that.
coming to you with that.
Yeah. So technology is evolving much better than what it was. This is reliable, reproducible, good for the patient as well as for the surgeon. Today's era, we can definitely, we can document whatever we have planned, which is critical. And as all the users here, they have highlighted that less releases, less handling, and less pain. All of us have seen those results. So definitely, it has helped, and it has helped me as a surgeon to grow and to understand knee replacement in a better way. So that would be, that is my observation.
With a better understanding, you mean to see that even your conventional gets better. The whole perspective of knee arthroplasty becomes even fine-tuned. What's your take on this, Dr. Shailendra?
Dr. Neeraj said, the science is changing every day in every field. The patients are becoming more educated and more demanding. So on the same other side, as a doctor, as a joint replacement surgeon, I feel this automated robotics is an attempt from our end to give 100%, results in out of 100 of, so that definitely that is going to help us to achieve that goal, which was a bit difficult in conventional way. To some extent in the other navigation and this system, but I think this system definitely will, and step towards the achieving complete role.
So let's say what the literature says about these things. So it's a JBJ study, robotic arm assisted total knee arthroplasty associated with improved early functional recovery. So they have proved beyond doubt that it has decreased the analgesia requirements, decreased reduction in the postoperative hemoglobin, postoperative physiotherapy session, minimal blood loss, etc. All those advantages were proven beyond doubt. This was a recent study in the Journal of Arthroplasty, which again concluded with all the published short-term results. It's excellent, but we need a long-term follow-up to finally comment on all those things, whether it makes a real difference in long-term or not. So this has been discussed again because in terms of coronal malalignment, it's going to make a big change with the robotic assisted navigation, even better than computer-assisted navigation. This is again to Neeraj sir, because you were there with a brief period for a passive semi-active navigation system as well. So how do you rate our active robotics superior to semi-active? How is the workflow different in terms of getting the your targets hit properly?
If you compare other systems with QAs, not because we are here in Merit Academy, on a neutral platform, and then unbiased opinion, if you ask me. The pre-op CT planning definitely helps to reduce your OR time and far more, to achieve more precision. Also, the locating hip center or ankle center, all such steps are avoided. And they're far more precise with CT than with the manual technique. Other day, actually, when I was attending one of the meetings, and then they said, is a hip center is located by rotating the hip in circular way. I said, where it locates? No, sir, it is software based. Then what next shaft angle is taken into consideration? What is the angle of anteversion? How you locate? What is the size of the femoral head? So all such answers are, they are unanswered actually, all such issues
Exactly.
where they are non-city based, machines or technology. So in a way, it is, in short, it is a good, precise system. It definitely it is giving us, consistently over the period. I mean, all of us have achieved what we were doing non-robotic way. I mean, the OR time has reduced drastically. I think Sujay will also agree with me.
Yeah, I do agree, but let him finish, then I'll talk. Issue is that if I ask me, how do you rate the conversions from conventional to navigated? I've been using navigated since 2007 or 8. We're using the NAP3 striker. But everything depends on my patient satisfaction. If you say you two papers, what you have shown, these all people says like this. Less time, not at all. Not less time. It is a, you can say the guys who are operating a high volume center, a surgeons operating with conventional jig and operating with this robot, definitely the time is less in conventional. I'm talking of the high volume center.
Exactly.
This robot is good only the trained person's hands. You need to be a trained person. If the young guys come and say, yes, I'll do miracle with this robot, not at all. You need to have, because what you planned, that will be executed by this robot. Another thing is that less pain, there's a reason behind it. Because see, they're using bar and continuous water flow. There is no micro damage of this bone cells. Because while you are cutting, even if the semi-robot, semi-active or a passive robot, the planning, it is cutting the bar or something like saw, but there is no continuous water flow. What I have seen, why my patients are less painful after surgeries, maybe because of that, because any cut robot is doing with the continuous water flow, that is not damaging the bone. And another thing is that using the one posture, he finishes all the cuts in very less time.
So amount of microscopic bone necrosis is
not there. That might be the reasons why there is a not pain. Definitely, I'm saying this robot is only, this will lead the world. This will lead the world because there is in behind it. Definitely is a more precise. Nothing wrong with it because I've done a couple of surgeries, more than 200 surgeries I've done. Not a single case, anything happens wrong, that is because of my fault.
Right.
Because of human error. That is not because of the QS error.
Okay.
Anything's wrong, either they agree, they change the software. See, that is a softening. But only issue is that you have to be planning properly on the CT scan. That is the best part of doing it. Because you know the things, what they exactly there, then accordingly we can plan executions. The imageless is really good, I suppose. I feel that.
So to conclude, basically it's not an extrapolated software image. Rather, we have a original unique image of the patient's distal femur and proximal tibia on which we built, and the HK axis as well. Perfect. So coming to the again are we a mechanical alignment surgeon, functional alignment surgeon, kinematic alignment surgeon? Dr. Agil has already given us a beautiful talk on how he performs himself being a good kinematic surgeon or a functional alignment surgeon. Dr. Agil, you can enlighten us again on this. And what is your point to emphasize that being a minimal soft tissue release, how do you benefit? How do you claim your patient benefits?
Thank you, sir. Firstly, when I examine my patient clinically and when I see that there is a fixed flexion deformity, there is a rigid varus deformity, so I make up my mind, okay, if I don't put my tibia into varus, or if I don't play with the rotation, if I don't play with the implant, so then I have to release a lot. So before my planning, I examine the patient and then I make up my mind I have to do this. So initially, I keep my tibia into 2-degree varus. I always, it's my with my little experience, I just make up my mind, okay, my posterior medial and posterior lateral condyles will have a difference of around 2 mm, 2.5 mm, just because I don't want to play with posterior medial soft tissues. I don't want to do pie crusting of anterior fibers, superficial MCL. I don't want to release posterior medially tibia. I always do a tibia reduction osteotomy. That is very essential. So my funda is keep when you are not touching the soft tissues, the soft tissue envelope is intact. Naturally, patient will have less pain postoperatively. Recovery will be fast.
But do you
And-
think this is only an immediate post-operative gain, or
Yeah.
can you extrapolate the same thing to a long-term benefit?
So unfortunately, right now, there are no studies available of functional alignment in a long-term study. I guess only it's like for a couple of years or 3 to 4 years studies are available on the internet. So let's see, but then I am satisfied that I have not touched soft tissues. I have done accurate bone cuts. So I can sleep happily.
Welcome, Dr. Chandrasekhar. Is joining with us.
Yes. Hi, Dr.
Hi, sir. Good
Asif.
evening.
Good evening. Good evening.
So, in the area where we argue,
I'm more of a mechanical guy, so I really believe in that. But I don't take away from people who are doing functional alignment, because I don't think so. Couple of degree varus in tibia or couple of degree varus in the distal femur should alter the overall dynamics of the principles of doing a knee replacement. But yes, I'm more of a conventional guy, and I'm happy with what I'm doing. But I don't discourage somebody doing it, or I should embrace it in future. But as of now, I'm sticking to mechanical axis alignment, and then I'm quite happy with it. Yes, I do. I need to talk to my colleagues who are doing high volumes with the functional alignment and see whether I can embrace the technique. But I am not against embracing the technique. Yes, if in future I am convinced, I'll definitely embrace the technique.
points well taken, sir. Now, having said all these things, what does literature has to say? As Dr. Sujay has rightly mentioned, the real impact of others' financial conflicts on robotic-assisted joint arthroplasty research. The study says it's almost about 92% of the studies published so far in this contest has been industry-driven. Okay, so this is a brief of how the authors have received payment to publish similar results, similar studies. So we are in a state where we can't rely entirely on those studies so far published in this contest. But still, these are the options left in front of you. You have to follow it. You have to accept it. Now, in terms of implant sizing, accuracy, and precision, Dr. Shekhar.
Yeah, definitely. I think the accuracy in terms of implant sizing is quite good. Now, my experience is not much, around 15, 17 cases. And in one case, we had to downsize, or else the implants were exactly the ones which we decided pre-op in the planning stage.
Any of the expert panelists over here, have you ever faced a situation wherein you think of upsizing would have been better? Because especially in case of a severe valgus knee, wherein you find it difficult to balance the flexion space. If there was you've done a good preoperative planning with your CT, but even then you realize that one upsize option, if it would have been there, would have saved a bit more space for to balance your flexion space. So, and our software doesn't allow that, upsizing the femoral component.
Very good question. I mean, upsizing option should be there. Probably they are working on it.
Okay.
And so to balance the flexion gap, you should know when you are done the planning, how flush you have kept the femoral component to the anterior cortex, how much space you have still to posteriorize it to control or reduce the flexion gap. Actually, of late, we have started this practice of, I get that final planning, whatever we had done. So that screenshot is there with me. And the lateral or sagittal image of the femoral component and the anterior cortex after hiding the femoral component while planning when we do that. So on table, I know that, okay, I have at least couple of millimeters to posteriorize it if required. So that is one. But in gross variation is there more than 5-6 millimeters. This has happened twice. where I opted for extension surface and then went ahead with,
You
this
completed the full
proper-
surface after getting the
and
balances,
I
right?
used sizer and completed the case. But this happens very, very rarely.
Very rarely, only in normally in severe valgus cases.
Yeah, if they give any alteration in the software where they can give us an idea about the soft tissue balancing in a pre-operative planning, that will definitely mostly solve this problem of downsizing and upsizing.
But I think it will be practically very difficult to get the soft tissue tensions based on the CT imaging, right?
I think the major issue in India is the disparity of the MLAP diameter. It's a huge issue. Recently, Mr. Choi, I know you might be knowing this guy, he was with me. Even he was also disappointed because it's very difficult many of the times. Because medial lateral is so wide, AP is short, AP is so long, medial lateral.
The disparity
It's a very big issue. I think the issue is that sometimes so much of osteophyte either sides, very difficult to gauge which exact implants will be there. Even in the one up, it's difficult, I think. It's not just so easy. Another issue is that I think what I feel, what I see, how much is cutting the posteromedial and posterolateral. That is the only way you can decide whether you go for the upsize or downsize. But that has to be at least 6 or 7 in between. If it is posteromedial or posterolateral is cutting for it, is very difficult to balance the knees. So that may be one of the, that is my opinion. I don't know the rest of the.
Other thing which you can think of doing in such scenario where you have, say, 13, 14 flexion gap and 7 or 8 extension gap, and all other planning looks okay. So couple of millimeter, if you have, you can posteriorize the femoral component and then you can increase the distal cut to increase the extension gap. So that will help you to match both the gaps. And then last option is to opt for extension surface.
So to conclude on that, there are different studies. We have to believe this. Okay, don't. I'm not going with my previous slides on financial interest on those things. Literature says 95% femoral implants within one size and 99% tibial implant within one size. And on the alignment, accuracy, and precision of robotic surgeries, it's like 3 times more accurate and 3.2 times more precise as per the recent indexed published journals. Regarding the learning curve and surgeon impacts of the newer technology and innovations and the workload that. Yes, CP sir, you want to add something on?
Yeah. So the the oversize of the femoral component comes in one of the main situation where you have a flexion deformity, where you need to oversize the component because you want to cut less posteriorly so that you buy more bone from the tibia, so that you can use the tibia for your extension deficit. So what you can do is, what Dr. Adkar was saying, that if the flexion gap is about 12 or 13 and extension gap is 8, so one option is you can choose the extension to flexion balancing. But if you fear that the burr will go posteriorly and cut the soft tissue when you're oversizing the component, that is the biggest fear the surgeon can have. So what you can do is you can cut your distal femur and then go for the tibia, balance from extension to flexion. That is one option which is always there. Otherwise, what you can do is you can once you cut the distal femur, you can flex the component at least until 3 to 4 degrees. Once you flex the component, you can accept a 1/4 millimeter of notching. Nothing should happen because you already flexed the component. There won't be any stress riser in the supracondylar area. That also will get your flexion gaps reduced. Second option. Third option is, if you have a fear that there is no way, this is 20-degree flexion deformity, I have to oversize the component, then the option left is, even after flexing the component, even after accepting a 1/4 millimeter of notching, if you fear that by oversizing you may get into the soft tissue posteriorly, but usually even our blades dip into posteriorly, both posteromedial and posterolaterally when you are doing conventional or even navigation, nothing should happen. But if you still have a fear, then you can complete all the cuts, make the tibia and use the ligolds, behave like an anti-referencing surgeon. You can always use the conventional jig and go ahead and cut it. Option 1. Option 2, you can cut half of the posteromedial, take it back, cut half of the posterolateral, then continue your cuts with the blades later. So these are extreme cases, but these are the tips and tricks which you can use it.
Rare scenarios now. But mostly now on the femoral sizing, the problems happens when you don't have the implant in your inventory. So that's how you start modifying. Am I right, Manish? So regarding the learning curve, surgeon impact, and the workload, Dr. Sanjay, what's your take on the learning curve aspects and the workload?
Initially, I thought the learning curve for me will be very high because I stopped using navigation after say about 2011. One of the hospital where we used to use navigation was used to keep dry the clothes, you know, and ultimately they sold it because we thought probably it's a waste of time and we could do faster. But I think one of the best thing which happened to me was I came to Wakwi 2 or 3 times, and then I visited Dr. Adkar as well as facility at Bangalore. And that's why probably we could lessen or shorten our learning curve. And I think once you get the tricks, you know, and certain points where they learned it with maturity or with their numbers, then I think the learning curve can be really shortened.
So
And
with the
it's
degree
always
of
better to go and spend time.
with the degree of freedom that this machine offers, its learning curve is pretty low. On any robotic surgery, this is not just related to QVIS. On any robotic surgery, the learning curve, as per the studies published, is just about 20 to 40 cases. But I think anybody who was navigating before, it's just a matter of less than 10 cases. Or for any non-navigating surgeon, it may be 15 to 20 cases should be good enough. And someone has done the study on this surgeon posture and workload and all those things, and they've concluded that end of the day, it's robotic cases are real fun.
So let me just add here. Actually, our OT staff is more happy with robotics. Sir, बहुत अच्छा है sir. काम कम करना पड़ता है. So I mean that's a genuine feedback. They are standing watching there and robo. Actual meaning of robo is forced labor.
Forced labor.
So it's a forced labor. So you are asking someone to work for you.
Has, you know, at some particular time use some, you know, that tool, either navigation, patient specific needs, or, you know, this thing. So I don't think in practically we are really facing this problem.
Exactly. Regarding patient reported outcome measures, Dr. Sujoy. From your experience, how do you want to conclude that your active robotics is a boon to add on to your patient reported outcomes?
See, I'm telling you, only issue the pain. Only
Pain
recovery,
is literally non-specific. It's like
see, I'm telling you the
conventional
recovery
surgery, pain
time,
is there.
if I compare to the normal conventional surgeries and navigated surgeries, and honestly, I'm very honestly telling that. So there is not much of difference, but immediate post-op pain is less with the robotic surgeries.
Pain is less. You want
Less pain.
okay.
Patient more comfortable, range of movements is very high, good. In the next day, patient is more than 110, 120 degree flexions is there. So this is better. The less pain patient is more comfortable, more confident. The weight patient leave the hospital, they're very happy. This way, I think, is better with the robotic surgeries. Everything I'm measuring patient outcome.
Any scoring you have done to validate your statement, like a MOMAC score or any knee scoring system?
Yeah, my colleagues are doing I feel that every score is my patient. What patient says, what I'm
Patient's
getting.
feedback is your scoring.
Forget about what amount of surgeries, surgery time, these and that. I'm not considering that. But if I consider my patient is the only criteria to decide whether this surgery is good or not, I definitely say the outcome after doing the robotic surgeries, conventional surgeries, and navigated surgeries, this robotic is the one.
Neeraj sir, your word on more than 400 cases now.
As Sujay said, I mean, the pain or drain has also reduced. I mean, less blood loss, that is significant. So we are in a process of publishing our data. First 100 cases we have already submitted, and with these findings. As one of the speaker mentioned about the physiotherapy is also
Number of sessions.
yes. So sir, range of movement, I mean, they are also happy, or so definitely it has helped. And whatever data we publish as a surgeon, if patients are not happy, any technology like navigation is going to fail. But here we are seeing patients are happy. So that's why, again, not because we are here, this will grow. This technology will grow.
As Dr. Sanjay was mentioning in his talk, it's not just the patient is telling about it, even the physiotherapist is.
See, our experience is very, very minimal for last 3 months. But in fact, the physiotherapists are commenting, means have you done something different? And majority of the patients after 2 weeks, they are phoning us, ki doctor, azun kai goळ्या घ्यायच्यात का? Means, do we have to take any medicines? That's like a music to our ears, Otherwise, for first 1.5 to 2 months, all of us agree. Patients keep on pestering what medicine to take, what medicine.
Sitting on our head with pain.
Exactly. Means this is very, very early. But I think what unfortunately prospective randomized clinical control trial is not possible. You cannot deny the patient. You cannot operate one side conventional, one side robotic.
So I have a story to share here, because I have a patient. His wife, I have operated on her in 2015, normal conventional way. And this guy was also having a problem with his knees. He was working in Gulf. And I suggested him that you also should undergo a TKR. The 2017, I advised him, he was working in Gulf. He don't want to get it done. So he stood with his pain for almost 5 years. Last month, January, I operated on him. And this guy made a video and sent it and shared it with me that if this was the case, I wouldn't have left my job in Gulf and came back, because I was thinking that I'll be having pain for such a long time that my wife suffered in 2015. And in 1 month, he is absolutely pain-free. So he feels guilty and he feels dissatisfied that he should not have left his job in Gulf and came back, because he thought after the TKR is not going to go back again. This was one, I could even share that video because it was like a talk from his mind.
Only one thing, like previously the conventional TKRs, sitting in OPD and observing following the patient in OPD for first 3 months was a bit painful as a surgeon.
Exactly.
Answering questions, giving medication, or playing within the 2-3. But now in last 2-3 months, we are enjoying the, following up the patients who are operated with this system. So
Perioperative technical issues encountered. Sujoy sir, any technical issues you have encountered that you have to convert it into a conventional to finish it off, or the like I mentioned in my the predefined tech complications like MCL, extensor mechanism disruptions because of the robot?
Yeah, I do. Because some difficult cases, some varus deformities with lots of osteophytes are there. Sometimes I feel that it is not possible because so much of defects in the medial sides. It is very difficult and very risky because we don't want to take the risk, because still only the couple of, because it is very new to, at least in my practice, I feel that. So I don't want to experiment with my patients. So gradual, I think it is if it's a learning curve, it is a steep learning curve. Still I'm learning. So in such cases, couple of cases are the very fatty, obese, osteoporotic. Main issue is the pins. Very short-heighted, obese, osteoporotic patients. My main
issue is your 4.5 mm pins.
Yeah, I postponed. I don't want to take the risk.
Any of the panelists here had any?
Actually, this pin issue was discussed during his presentation in morning as well. And I discussed with Dr. Londe and other team here. From last couple of days, around 2 weeks, we are from shank pins, we are shifted to 3.5 mm K wire. And on femoral side, again, we drill with a K wire, we take out the second hole. And then we use a smooth Steinmann pin, which goes in smoothly. So unlike Shan's pin, and there are no issues of pin breakage and absolutely safe. So, and trackers are also absolutely steady. There is no issue with that. So in osteoporotic bones also, I suppose it is good because one of the holes you have reduced the size, and so it is safe. So you can try it out in next case. It is working, it has worked. And no issue with the registration process, no issue with RMSs, and everything went on smoothly. This actually, this issue cropped up intraoperatively because we used to put the pins directly without drilling a pilot hole with a drill bit or with the Shan's pin directly. So obese patient, it was difficult to, while putting that pin, it was difficult to get, hold of, and that holder was, getting out of place, and it was, all of us faced that. So I first inserted the thick K wire, it went in smoothly. And I thought, okay, I'll put that K wire first, take it out. And then, in fact, my OT sister suggested, so why don't you try the Steinmann pin instead of the Shan's pin? And it just went in so smoothly and worked wonderfully. So in obese patients, especially, you can try it out, it will work, and it is safe for the patient.
Good choice.
Right now, I'm with this Curexo guys. We already planned and some pins, different pins. The trial pins I'm supposed to receive, but Sang Li, unfortunately, he will not here. If it was, definitely I'll go. I request Dr. Manish, he will let us make a group. Then I can get this in that pin. It will be 3 mm, and the thread will be 2.5 mm. Because see, I always engage the first cortex. I never touch the second. It is just engaging the second cortex. I'm worried about only the femur, not anything else in the world, only the femur. And if it works, definitely you should think for that, because these are trial pins. This, I think within a month or within a couple of days, it will be with me. Let's try with that, then I'll get back to you guys. Because in that pins only on cortex, which is supposed to. Another thing is that Steinmann pin, if you say because the marker is very important. If it moves a little bit, then everything is gone. The stability of this marker is very important. Because the Steinmann pin is smooth pins, the holding of the pins and the sand screws is different. The holding of the purchase will be better in that. Or if it is 2.5 mm, right now we are using the 4 mm. So reducing 1.5 mm. So I think that will suffice. That may. Another thing is that I request you, all of us should do our pinning ourselves.
Yeah.
Because when you leave it to your colleagues, they do something ulta-pulta.
It's a real concern in our short obese osteoporotic ladies.
He's worried about only the short-heighted osteoporotic femurs, short height. Because in the mid shaft of the femur, there's a very narrow, width is very narrow.
Any other panelists have ever faced any of these complications in our limited experiences?
I think these trackers are very sensitive, even the camera. So sometimes what happens in one case, because of the breathing, it was not touching the tracker, but because of this breathing, her leg was moving a little bit. And then this will stop, the burr will stop because there is excessive bone movement. So
we have also faced this issue, especially short-statured, obese with huge abdomen. Patient is awake because you don't sedate the patient.
Yes.
Invariably, they will start snoring. Okay, so never sedate the patient till all the cuts are over. They start snoring, abdomen moves, the tracker moves. Bone is unstable, it will stop. So how we have overcome this problem? So I asked my assistant, don't laugh at this suggestion. So I asked my assistant to press the patient tummy and this works. Okay, this definitely works. Okay, if the tracker is moving because of the huge abdomen, someone presses patient's tummy, it works. And one patient, we had to convert that into GA. And once you convert into GA, then anesthetist can control it till, and especially you face this issue at the beginning when the Miller starts. once the cut starts, usually don't, and especially at the distal femoral cut. So once that is done, then so last option is converting patient into GA. Otherwise, that good assistant with good biceps and forearm will help you.
In fact, our first case we did at our center, the trackers are there, femur, you put it on the shunt pin. One of the ratchet, it did not work. So we had to put some tape or something. So I request the company, like we have 2 or 3 saws during the operation. I think you should have a spare trackers, not only one for femur and tibia, because I think the ratchet has some spring action, and if it goes, then exactly. And then the end of the operation, actually, fortunately, we could, everything should be 2. Exactly.
Actually, I've checked with them. You should have a backup this thing for trackers and all this thing. Then they told that Curexo has, am I right, Samir? Regarding the clamp also, Curexo has reduced the price only because of these things.
So this clamp, I have switched it to conventional external fixator clamp. It is working.
Okay.
100% it is working. Okay. So this Indian experience probably we'll discuss it during our meeting. Keep it. I mean, day one when I saw that clamp, I asked my OT staff, "Ek do clamp आप डाल दो इसमें ऑटोमेटिक करके रखना है, we will need it on table and it has worked."
Sorry? Yeah.
कोरियन लोग पागल हो जाएंगे.
So coming to the last part. So this was one great paper from our great Parvesi et al. Parvesi et al. Robotics in hip and knee arthroplasty.
Sorry to interrupt.
Yeah.
And just addition to that, if unfortunately that clamp is not working, so I have faced this situation when that clamp was not there in the tray, the channel clamp routine. So the good clamp, you put it on the femoral side, which is not working on the tibial side. And the locking mechanism of that rod will take care and you can still complete the cuts. Yeah. Okay, attachment. Okay.
Because there is a small spring there. If somebody sort of tightens it very
But the
hard,
array is attached to the clamp.
array.
Actually, that's problem on the tibial side. Femoral side, the array is on this side and tightening is on the opposite side. So it never happens. But tibial side, array and the tightening is on the same side. So you people have to either shift the, make a such that it should be on the opposite side. So it will never fail. वो टेढ़ा करना पड़ता है और टेढ़े में वो spring.
And I think we should have backup.
One backup. Dinesh, so final listing, the robotics in hip and knee arthroplasty. This is from Parvesi and team. They have raised this question whether it's a real innovation or a marketing ruse. So Parvesi and team has raised so many concerns that it is going to take extra time. But we know as we progress, we are not taking any extra time apart from like 15 minutes plus or minus 15-20 minutes, which is quite insignificant. So all these things is linearly correlated to complications like infections, DVT, etc. But he also has concluded that if it's going to be really beneficial and cost effective, then this active robotics, the beneficial to the industry, is going to be substantial. So with that, let us conclude this panel discussion. Thank you.
Pardon my ignorance, but as I have come to know, this system relies on pre-op CT planning.
Yes.
And that CT scan is non-weight bearing, right?
Non-weight bearing, yeah.
So does it make any difference when we are planning everything on a non-weight bearing HK axis?
See, in active robotics, you are taking into account all the soft tissues. You see, what difference it's going to make? It's going to keep some lateral side laxity, right? in weight bearing.
Yes.
So you're taking into account into that because you are finally accepting only a rectangular flexion, rectangular gap balancing. So whether you do CT on a supine position, you are doing the surgery also in a supine position. At the same time, you are stressing on your medial and lateral side to get the balance right.
So CT is for planning the bone cuts. Gap balance, you plan intraoperatively. So when you get the weight bearing X-ray and you see varus and stretched out ligament, what do? You balance it in the inside the OR.
Correct.
That same thing you do it with this system also. So inside the OR, you check as demonstrated by many surgeons today, flexion, extension gaps you check, and you have option of modifying your pre-operative plan. It is not that the plan which you have finalized before, you are continuing with the same. You can still fine tune your plan to balance the gap. And as an orthoplasty surgeon, I think that's what you aim for.
Correct. So pre-op, basically we are just
Pre-op planning,
sizing more.
It
more
is
of a
not just
sizing.
sizing. It helps you to locate the hip center, ankle center. And if you do it properly, intra-op modifications or changes, you don't need to do many modifications or changes. And or as you do many cases and you gain experience in this, you can see looking at the CT image, okay, you just need to rotate it or you need to keep a difference of around 2 millimeters. That helps you to balance intraoperatively as well. But still, this system allows you to modify your plan intraoperatively.
Okay, thank you.
One question.
Thank you.
These markers, the white markers, they are very sensitive. Protect them from getting soiled, by putting the Camgy pad. Are you using the same markers for how many cases, or are you using all new markers for all the cases?
If they touch too much of blood comes to the doesn't make a difference.